I'd like to thank Dr. Poulang for hosting the webinar today. And I'd like to thank all of our esteemed panel, and including those folks who made the wonderful videos that we've watched today. So we're obviously at the top of the hour, but we would like to move into a question and answer session. So we will continue the webinar for a few minutes after the top of the hour. We'd love everyone to stay with us if you are able to do so. But don't worry if you can't, because we are recording this session and we'll be sharing a link with all of the attendees after the session. So if you have to drop off, we totally understand, and would invite you to view the link to the webinar afterwards. But for now, I'll be posing some questions to our panel, including many excellent questions that many of our attendees today submitted when you registered for the webinar. So thank you so much for those questions. I've tried to collate them together to capture the main items and get some reflections and thoughts from our panel about those issues. So I'd like to start with the first question to Dr. Euphemia Sibanda. We received several questions about how to improve access to family planning in culturally or policy restrictive settings. Do you have some thoughts on this issue, especially for hard to reach groups, including adolescents? I'd like to invite our panelists to turn their video on as well when they're speaking, if possible. Over to you, Dr. Euphemia.
Yes, thank you. Yes, so I think to optimize uptake of services in all settings, it's important to have a good understanding of the cultural beliefs and the barriers associated with uptake of services for each population. So make sure that you have context-specific understanding. That way you can then be able to craft your models or make your models fit the context by addressing those challenges that they would have they encounter. If we're talking about young people, for example, in Zimbabwe, there's been a lot of talk about resistance from parents and religious groups about access of contraceptions to young people. So it means your starting point might have been to address those barriers at policy level and at discussions, discussing with parents and all the other related stakeholders so that you can get people to accept such an intervention, because without addressing those barriers at a structural level, it's difficult to then get the young people to access the services.
Thank you so much. I think your point about working with local communities and understanding the local context is such an important one. Thank you very much. My next question is to Dr. Judith Aloyo. There were many questions about diversifying the method mix. And there seems to be widespread agreement that diversifying the method mix and expanding access to contraceptive products has benefits for both individuals and communities. That said, how can we improve information streams for end users so that people know their rights, where they can access quality reproductive health care, and how they can have accurate and unbiased information about various methods, including the long-acting methods that you spoke about in your presentation?
Thank you very much, Sandra. And I thank the attendees that were able to share with us those questions. Now, looking at the number of end users and how we can be able to reach to them, I touched a bit about this in terms of the service providers. We have the mass media. At the community, we also have the community resource persons. But also, we know that we have the champions, but most importantly that we saw, which is a gap, is the technology or the mHealth. So in order for us to be able to improve this, I think that is one of the key gaps that we have as a region. And when I touch on the aspect of media, our region is having close to about 10% media coverage or technology coverage in terms of the smartphones. So the easiest way for us to be able to reach these end users is through the interpersonal communication agents or through the radios, which is the simplest communication mechanism, but also the fact that we have equipped our health workers to be able to provide this quality service and also be able to access. So in other words, we have improved the environment in terms of the availability and somebody to be able to go and ask either at the health facility or to ask using even the person at the gate. So we have a range of lay workers right from the community to the facility level where our end user is comfortable enough to ask something about family planning. In addition to that, as a project, we have embraced a bit of mHealth, and we have especially around the area of HIV in order for us to provide some reminders to our clients. Interestingly, even the HIV positive clients should be able to access family planning because it's the first prong in order for us to reduce the incidence. Therefore, we would want to use this platform to be able to try and integrate provision of either HIV-related services and also include family planning because it's the same beneficiary. Thank you very much. Back to you, Sandra.
Thank you so much. And I appreciate your point about integration, which was also highlighted in Dr. Sibanda's presentation as well. So a really excellent point. Does anyone else on the panel want to make a comment about that question regarding diversifying the method mix while also ensuring that end users know their rights and have accurate information? All right, well, let's keep moving along now. So I actually was going to ask Dr. Betty if she would be willing to reflect a bit more on the policy environment. We've heard today about some new exciting innovations on the horizon that could potentially increase access to contraception. But as we all know, many novel programs and policies never make it to scale. And we often hear that evidence is not enough. So I wanted to know if you could say a few comments about what we can do in the research and policy communities better or differently to help innovations reach scale.
Thank you very much, Sandra. I think for our policies, you're very right to say they don't get to scale. And one of the things that we have seen that seems to work so well is working more with the beneficiaries. For example, in Uganda, the adolescent health policy has been on the shelves for close to more than a decade. But I have seen this process of finalizing and ensuring that we implement the policy being accelerated when we work with the young people themselves. We have a number of youth-led organizations that are promoting sexual reproductive health programs, and we have seen them taking lead as champions for the adolescent youth health policy. It has not yet been finalized because there are a number of steps that must be undertaken. For example, ensuring there is a regulatory impact assessment undertaken, and this has been concluded. The policy is already in draft form. So these have to go together to be discussed in cabinet. And if it were not for COVID, maybe this process would have been finalized. But I think working with the actual beneficiaries or the target audience that we are aiming at makes wonders. And ensuring that they are champions, those that can ensure that they knock on the doors of the Ministry of Health. Where are we with this policy? Where are we with this kind of, helps a lot. And then for me, one of policy issues that I think has helped us to step up family planning utilization, as I said in my conclusion, was linking family planning more to development, because in so many African countries, we are aiming at supporting countries to harness the demographic dividend. And there's a lot that we can do using evidence to advocate and to ensure that our policymakers understand that family planning is not only to improve the health of the mother or to support families, but it contributes a lot to overall national development. Thank you, Sandra.
Thank you so much. Your point about having a Ministry of Health champion involved from the beginning of a project is a really important one in my mind. Thank you for sharing that. So my next question I'd like to ask of Mrs. Dorota. we received many questions about the role of religious and faith-based leaders and how religious and faith-based leaders could promote acceptance of family planning. And I wanted to ask your reflections on this, and also if there are any promising models that you're aware of that can leverage faith-based leaders to increase access and utilization.
Yes, so my bandwidth is a little low. I'm gonna try to put on my video, but if it gets so low, I might put it off. So the challenge of working with religious, traditional, and other cultural leaders is that they need to be informed and involved right from the beginning. And just
I'm afraid we can't.
Evidence-based advocacy. They need to see the number of young people getting pregnant and tag cost both advocacy and demand generation. Sometimes the leaders, the traditional and other leaders,
look like we might be having some connection challenges. Maybe I'll ask the rest of our panel, Dr. Aloyo or Dr. Sibanda, any thoughts on the role of religious-based leaders?
Yes, I can say, Sandy, thank you for the question. Religious leaders play an important role, and they are important people to engage with messaging on family planning, because many people actually fail to take contraception or decide against it because of the influence that they get from religious leaders. So it's important that religious leaders are given information as well as asked to raise their concerns so that they can be addressed. A lot of the concerns related to lack of understanding or false information that spreads in communities. So it's really important that we get them to have good understanding with correct information, and that way they will not be barriers to uptake of services. Over.
Thank you very much, Sandra, for that question. Now, when we look in our context as Uganda and northern Uganda, we can have religious or cultural leaders in two-pronged. They can either be influencers to the uptake or influencers to the low uptake. Now, we were forced up with this kind of challenge, especially the fact that we have 60% Catholic-based or a Catholic community. But also among the health facilities, we do have about 40% of these health facilities that are faith-based. So what we did as a project in order for us to ensure that we can use them is that they do have some form of contraceptive method, which is what they call fertility awareness method. So we brought them on board, and they were able to appreciate the fact that they are not able to take the modern contraceptive methods, which include maybe the sterilization, the IUD, which is against their faith. They're able to take out other methods which are with their faith. So we are able to turn around their concept and understanding that, yes, they also have a role to play, that much as they're not advocating for this that is modern, they are able to also embrace the fertility awareness methods. So initially they were a hiccup, but having brought them on board that they are able to also have areas they are able to influence on, for us has been one of the things that we want to continue leveraging on. And therefore, in the slide that I earlier presented, it was also clear that we are seeing some of the fertility awareness methods also improve. So depending on how you address and attach their importance to you, I think they are key in terms of being very excellent opinion leaders, but also that the people usually tend to listen to them, and therefore we cannot kick them or push them aside. We need to embrace and see how we work with them. Thank you.
Thank you so much. Excellent points. And it sounds to me like you have very similar thoughts as our colleague, Mr. Rhoda, who wrote in the chat because of the internet connection, that not only should religious and traditional leaders be engaged, they need to be trained to become advocates, which sounds similar to what you were saying as well. So thank you very much. So I'd like to thank our panelists and our speakers today for being part of the webinar and for this Q&A discussion, which was very rich. And I have a feeling we could talk for hours about many of these issues. But we're going to go ahead and close the webinar now. I'd like to thank everyone for coming today. And I hope that we have increased your appetite to continue joining us for these webinars. The next webinar will be in March, focusing on measurement of respectful care, which I think is a very hot topic, and particularly the focus on measurement. How do we know if we're being successful in our programs and our policies? And then in April, the next webinar will focus on urban health in East Africa, focusing on implementation priorities for health, nutrition, WASH among poor children and adolescents in urban settings. And there will be case studies presented from Kenya, Tanzania, and Uganda. So I'd like to turn the mic back over to my colleague, Dr. Poulang, to close the webinar. And thank you everyone so much for coming today. Dr. Poulang.
Thank you very much, Dr. Sandy. I would like to thank everyone for participating in this webinar, and to all the speakers for their valuable contributions. We look forward to having you in our next webinars next time. That's in March and in April. So thank you, everyone. And I would like to wish you all to be safe during this time. Thank you. Goodbye.
Thank you. Bye, everyone. Thank you.
Thank you. Goodbye, everyone.